Welcome back to another episode of the Hand to Shoulder Solution, giving pain the middle finger. I'm Carl Petito. I'm an occupational therapist and a board-certified hand therapist. I specialize in the rehabilitation of orthopedic conditions of the fingertips through the shoulder. So basically anything that's causing pain in that region from the shoulder on down, that's what I thoroughly examine and treat. I start every episode with a disclaimer. I want the public to understand that this is not treatment or advice. Basically, I would have to thoroughly examine each and every person to know exactly what is going on, because every person is different, every condition is different. There's many nuances within those realms. So this is information sharing that you may be empowered to make decisions for yourself in accordance with or participation with your healthcare practitioner. All right. So I want to continue talking about the wrist. The wrist is, such a complex area, such a complex region of the body. It's composed of 15 different bones and 24 ligaments which connect bone to bone. The wrist, you have here's the tip of the elbow. We have the radius and the ulna. We have the 8 carpal bones. They all have a name. We have the 5 metacarpals. And in this area, in this region, there's the 15 bones, okay? And there's 24 ligaments that connect them all together. There's 24 tendons that connect muscle to the bones that go over the joint. The wrist has been called a joint of joints. So people will say, I broke my wrist. But what does that really mean? It could be one of 15 bones that have been fractured or broken. So one of the most common ones is the scaphoid. So at the thumb side of the wrist is a peanut-shaped bone that articulates with or connects to the radius. And that is right here. If you can see that peanut-shaped bone. When you fall on an outstretched fall on an outstretched hand, most commonly fracture the end of the radius right here. And the scaphoid is right there too. So the blood flow to the scaphoid bone is very interesting. The vessel comes in from the fingertips going toward the elbow and inserts on the distal or most furthest point away from the body, the distal end of the scaphoid. So that scaphoid, that peanut-shaped bone, is kind of thin in the center. If you look at a peanut, there's a waist or a thin area in the center, and that's the waist. When that area fractures, we have to really be careful that the blood vessel that goes through the scaphoid and provides the scaphoid with its nutrients is not severed, because that other end of the peanut, the other end of the scaphoid closest to the body, could die, and that's called necrosis or cell death. So that half of the bone could literally die. So the hand surgeon really pays close attention to that and makes sure that that's not the situation we have. We can get into a lot of the different details of the different surgical techniques, which it's my job to understand, because I have to rehabilitate these patients post-operatively or after surgery. And I need to have a basic understanding of what the surgeon, what techniques the surgeon is using or used, and that really determines what I do in hand therapy following surgery for the safety of the patient, and then for the optimal outcome and getting the patient well in minimal time. But a lot of times these don't need surgery. They need to be immobilized, and I would fabricate a custom molded splint that is not only a thumb spica that immobilizes the thumb and the wrist, but also stops the forearm from rotating, and oftentimes also immobilizes the elbow Then we start weaning them off into smaller custom splits as time and healing goes on. So I just want you to have an awareness that if you took a fall and you probably have a distal radius fracture where the end of that long radius bone is fractured, which is really one of the most common fractures out there. But you also hurt the base of your thumb, and that's really painful as well. You make sure that you're seen by a good qualified hand specialist, a hand specialist surgeon, to evaluate that and make sure you're not having a complication. Now, I also want to talk about all the carpal bones that are assembled, and where they're assembled with all the 24 ligaments I mentioned, they're under torsion or tension, and that gives stability to the wrist. So that portion is like this on what we call the carpus. So that first row of bones, the base of the hand, the first row right here, there it's under tension. So let's say the bone was fractured or it wasn't fractured, but in either case, the ligament connecting the scaphoid to the lunate, that's the next bone right next to it, the lunate bone, and they live in this little divot here at they're called fossas, a little divot or a little shallow bowl at the end of this long radius bone. That ligament connecting those two tiny carpal bones is severed, then because things are under tension, now you got your scaphoid bone, that peanut-shaped one, and it rocks forward. And everything is shifted out of place. That changes the whole mechanics of things. So some patients will come in complaining that when I move my wrist in a certain way, there'll be a pop. My wrist will pop. There's specific orthopedic testing that I could do in the clinic that helps to recreate that, so I can thoroughly assess, are they having significant instability? Does this have to be referred to the hand surgeon? Are they looking at possible repair of the ligament if there's a ligament disruption? So here's something really interesting that you can do right now. You can touch your thumb, follow your thumb down on the palmar surface here. Then you have that thick group of muscles we talked about earlier. And you can go down to the base of your thumb and you feel in your wrist, there's a wrist crease right there. You can feel like a bony knob right there. You're on the end of your scaphoid bone. If you move your wrist toward your thumb, that scaphoid bone should rock forward. And then if you go back, it should disappear. It should go up. So you're palm down, you're moving toward your thumb, and now you feel it more prominently. Now you go toward your little finger and it rocks up. If that's happening, then that's great. Then your ligament is mostly intact. It should be good. If that's not happening and you always compare to the other side, wow, that's happening perfectly. Yep, over here I don't have any movement. In fact, when I move, it feels like it just doesn't want to go, and there'll be a clunk. So what happens with the clunk is the bone goes back in place where it should have been all along. And if it's not a painful clunk, we tend to treat it conservatively. That means it's not with surgery. But if it's a painful clunk, oftentimes you're looking at surgery instead of therapy, and then therapy after the surgery. So just know that exists. That's really the basics of a very complicated issue. Now, another thing that happens is look at these bones. So remember, just a quick review, with the hand palm up, the radius is now parallel with the ulna. When you turn the palm down, the radius flips over the top of the ulna. And so there's movement at the wrist right there. Well, what keeps that together? What if this can't be allowed to just fly apart? So there's a ligament here on the back of the wrist. There's a ligament here on the palmar surface of the wrist. So that sometimes will get disrupted, and with a fall, the ligaments will or can rupture, and we do what's called a piano key test. So we'll move the ulna and the radius on the ulna up and down and see how tight that is, and then compare to the other side. So if one side is, wow, we can really move that up and down, that's really loose. The other side is snug like it's supposed to be. And then they turn palm down as boy, they have a lot of pain. And then this ulna is popping up. You see that lump right there? That's the end of the ulna right there. So that if that's popping up really high, then it means these ligaments have been injured or probably torn. So one thing we do as hand therapists is make these nifty little gadgets that can go right over that area. So on me, that is right. So you got the carpal bones and you have this. It's about up here. So when they move, this stabilizes the distal radioulnar joint so that it stays in line, and the ligaments are allowed to move, allowed to heal. So in a really severe case where maybe, the patient's having a lot of pain, or let's say it's not quite a surgical issue yet, and they need something more than this, I'll put them in what's called a Munster orthosis, and I'll make a gutter here that has a couple of wings on the side, so it stops this motion, but allows the elbow to move, and it allows the wrist to move back and forth. And then we'll take him out of that Munster brace, and then make one of these, and then slowly wean them out of this, and then perhaps eventually go to some sort of smaller, more simple little wrist brace, and then eventually nothing. And then we start restoring strength with some specific techniques to restore the grip, the forearm rotation where the radius is moving around the ulna. You're going to start with some nice lightweight, and then really slow isometric, and then isotonic, which is movement. Isometric, which is just holding it still until it gets tired. Then we have some nice oscillatory tools that are weighted that cause a rapid contract relax. That's called plyometric strengthening. That works the muscles differently, and all in the name of restoring stability to that very complex area of the body, and nothing that causes any discomfort. So we really have to build that up again. And it's relying a lot on the home program. And again, I don't keep patients coming in and out of the office 3 times a week. It's usually once a week, maybe initially twice a week, but then once every week and a half, because healing with these ligaments really kind of occurs slowly and over time. All right, so we went over the scaphoid fracture. We went over the ligaments that keeps the radius and ulna together, but in rotating around each other properly at the end of the forearm. And again, this is just for a general awareness. Now, we talked about trigger finger earlier and about the nodule on the tendon catching on the pulley that keeps the tendon against the bone, popping up through, and how we treat that. What's the differential or a different diagnosis? Something that presents that's popping up, but it's not the trigger finger. Occasionally, I'll get a referral for a trigger finger, but then realize that it's not a trigger finger, it's a ruptured sagittal band. In the sagittal band, now, I want to remind you, there are a lot of tiny, small parts in a very small area. So the whole hand, especially the little finger, it's like a watch mechanism. So you open the back of a timepiece, you open the back of a watch, and there's all these tiny little moving parts. That's why I want you to think about the wrist and the hand. There is no room for error. One little thing goes wrong, and it's pain, and it's clicking, and it's snapping, and it's stiffness, and it's its deformity, on and on and on. So there's a thin little paper thin ligament. Remember, ligaments connect bone to bone, tendons muscle to bone. Goes over the top of the big knuckle, okay? The tendons, and you can see them on me, these tendons that connect these muscles to your fingers. So when these muscles contract, called extensor digitorum communis, or EDC, we abbreviate everything in the office so we can just talk to each other and passing in the hall. Hey, saw Tom, the EDC is doing better, it's feeling a little bit better. The index finger, it is great. Ring finger is still having a hard time. It has pain at P1. So, we have some shop talk so we can just talk quickly. So the tendon goes over the back of the large knuckle, and there's a tiny little groove that it rides in. But if it wasn't for this thin little ligament that goes over the top, the tendon would roll off of this. So picture this. So when you squeeze, that tendon still has to stay centered on that knuckle. Otherwise, it'll roll right off and go down into this trough, into this ditch. And that's exactly what happens. So when the finger bends and that tendon rolls off, and then now you straighten your fingers and it pops back into place. And that's what presents just like a trigger finger, where it'll pop back into place. But instead of happening here on the pulley on the flexor tendon, it's happening back here on the extensor tendon on the back of the finger. So you make the fist, it rolls off, and let me show you on the skeleton here. The tendon is the white part. So what's not shown here is the nice thin little sagittal band. Remember, it's paper thin, and it's hard to surgically repair because it's so thin, and so it's preferred to be treated with conservative means, meaning without surgery. So let's say that sagittal band is ruptured. Now this tendon of this muscle that's up in the forearm is rolling off and back. We have to prevent it from rolling off. So if we can fully prevent that tendon from rolling off the back of the joint, that sagittal band will heal on its own. Takes a minimum of 6 weeks to heal. I like to keep my patients somewhat immobilized for 8 weeks because it's such a delicate thing. So here's what we do. So let's say the patient comes in and they make a fist, and that tendon is rolling right off that middle finger on the back of the off the back of the knuckle, off the back of the joint. And every time they move, and then when they straighten, it pops right back into place. Okay. Now, what if that joint is held into a little bit of extension? So when they squeeze, that big knuckle is not bending down all the way. Wow, that just fixed it. No more popping. It's not rolling off. All right. Well, they're not going to walk around with a pen in their hand all the time. So let's make a nice little custom brace that they can use to slide on and off like a ring. And it wouldn't necessarily have to be this big, but sometimes we'll just make it with these 2 fingers. But here's an example. They slide right on, and the patient can use their hand and go about their day and, do everything they want to do, and write and grab things and, manipulate their, buttons and things. And that will allow that sagittal band, to fully heal up. And then after they would wear this day and night, they would take it off slowly and keep the fingers straight. Take a shower, wash the hand, dry off real well, then put this on. Because during the 6-week period, 6 to 8 weeks, if it rolls off even once, now we're back to square one again. So patient education, I really take time with my patients to explain the why. Why do you have to wear this all the time? And when you do have it off, and if you take a break from it, you're watching TV, your hands resting on your lap, or if it's on a pillow flat, that's fine, but you can't close it fully and normally. Otherwise, it's going to tear out again. So the patient education is crucial, so we have patient compliance and we have a success. I think over the last year, probably rehabbed, maybe 3 of these, and all of them came out 100%. It's not a very common thing, but again, I want you to have an awareness. There's a treatment for it. Sometimes, for various reasons, the patient does have to have the surgery, and we still, after surgery, will let that heal, the surgical area here heal. We still make a relative motion orthosis, and then we follow up with the patients a little bit differently after surgery, but we still use this. Now, stiff fingers, because the fingers, there are so many tiny moving parts within the finger, there's no room for error. So if you take the back of your watch off and you toss in a little bit of sand in there, that is, your watch is no longer going to work very well. There's no room for error. And the part of the analogy with the sand is, in the finger, it's swelling, inflammation, stiffness. So what's really hard on patients is, if there was an injury and maybe they were at the emergency room and they were told to just go home and wave your hand around, you'll be fine. These patients come back 6 months later because now all of a sudden, you know what, my finger never did move right. Now it's stuck out like this all the time, or worse yet, the little finger is the worst one to work with, and often the most underestimated because it's just little. But there is all the same structures, but now in a smaller space. So now we have a really hard time restoring range of motion. So let's talk about a really stiff finger. It had, it maybe didn't get the right treatment at the correct time, and now it's just horribly stiff. Well, we have a nice little device called a joint jack, where this goes over the finger, over the stiff finger, and let's say the finger just won't straighten. All right. So this is in here, and the finger is bent, just won't straighten, and then turn it until you feel a light stretch, and then stop. So what I like about this is called a static progressive stretch. If this was a rubber band or something, it never stops pushing. That causes what's called stretch reflex, where the body will try to protect itself, and it'll actually tighten the tissues more, because the tissues will tighten up and really resist the pushing. But if you have something that it stretches and then stops and holds that position solid, that's why I like the joint jack. So after a few minutes, the patient won't feel the stretch anymore because the tissue lengthened out. So then they can turn it a little bit more and advance it a bit until they feel the stretch again. And they would do this over a 20 to 30 minute period, advancing that slowly for a light continuous stretch. And I would have them, have the heating pad on for the first 15 minutes or so, and the heat will help relax the tissues. I joke with patients to, go out and buy a good used riding lawnmower and remove the steering wheel. Super glue the steering wheel right onto this so you can get right on that wheel and turn that screw and straighten that finger. And of course, they're looking at me horrified, and then we both start laughing. So, or a ship's wheel, that, you grab the cog of the ship's wheel, just turn that. Only joking. That should be very light and for a very light, steady stretch. And that's the joint jack. So, I want the public to have an awareness of, there's a lot of really nice tools out there. And with the splitting material, I can make any split that is designed to stretch a joint. I made this on a guy who had fireworks blow up in his hand. He had a lot of shrapnel in his hand, and his fingers were very stiff. I would put a pad here, and then he would tape his finger around the end of this and around to his finger to straighten out this knuckle. He would wear it for a period of time every day, and he did quite well, and got his range of motion back. I want to end this show with that information. I'm going to do some more content that will explain some other conditions, and we'll talk about some other common conditions that cause pain in the hand through the shoulder. I want to end with a dedication. I dedicate the show to Jesus, who continuously guides me to do right, to do well, and to continuously improve. As I get older, I get better at listening to him. My wonderful wife, who continuously encourages me to follow my dreams. My wonderful family, my teachers, and the community who raised me and taught me my values. Also, my professional mentors who were and are patient with me and continue to answer my questions and empower me to help others to my greatest potential. You know, for me, learning is very humbling. Because the more I learn, the more I realize how much there is left to learn. So in that way, learning for me is quite humbling. And every day I learn more. Thank you.